everyone, and welcome back for Season 2 of the Health Tech Edge, where we talk about the latest topics in healthcare technology with industry experts. I'm your host, Zoe Jacobs. Joining us today is our weekly panelist, Raheel Redawala, Chief Strategy Officer at Productive Edge, and our featured guest is Sarah Kachur, Executive Director of Population Analytics, Strategy, and Solutions at Johns Hopkins. Thank you so much both for joining us.
Thank you, Zoe.
Today, we're going to talk about population health, but first, we'd like to know more about you and your background in healthcare. Sarah, you're a doctor of pharmacy, and you've been working in population health with Johns Hopkins for more than a decade. Currently, you're leading the strategic vision for the Johns Hopkins ACG System, which is known for being the leading population health analytics software. And prior to that, you were a clinical pharmacist. What led to your transition from pharmacy to population health analytics?
That's a great question, Zoe, and thank you for having me today. So I started my career as a clinical pharmacist with training in pharmacoeconomics and pharmacoepidemiology. So I was spending a lot of time designing and implementing medication adherence programs, implementing medication therapy management programs, and measuring those outcomes. I gradually got to spend more and more time with the population health and clinical analytics teams, and migrated over to a role leading population health analytics in 2014. It's been an amazing journey and opportunity to learn my skills, use the combination of clinical and data skills to improve populations in Maryland and all over the world.
Wow, that's great, Sarah. And certainly Johns Hopkins ACG System has made a huge impact in the industry for many years. I think it'd be great if possible, for you to explain ACG System to our audience who may not be familiar with it. I think more importantly, can you provide an example of how ACG System is used in a practical healthcare setting, the outcomes it enables, and more importantly, how does your team support your clients in the use and adoption from a success perspective of the ACG system?
Sure. The ACG system is a long-standing suite of population health analytics tools. It's developed and maintained by faculty at Johns Hopkins in our Center for Population Health IT, and it has grown consistently over the years to have a very large U.S. and international presence. We've evolved the tool over the years as population health needs have grown. We started as a set of risk adjustment models, migrated into predictive analytics, enriched our pharmacy tools as the importance of that data stream has grown, and most recently have layered in tools in patient segmentation and social determinants of health.
Wow.
Our customers use the tool to understand their population's needs, very finely target programming to improve the health and outcomes of their populations. They can measure variations in the outcomes of those populations, design best practices, and identify high-risk patients for targeted clinical interventions. So we're the backbone of a successful population health improvement strategy, which is becoming more and more important as the healthcare dollar is stretched. And we're moving both in the U.S. and internationally towards more value-based and total compensation-based payments to improve outcomes among patients.
Sarah, I can imagine, as you mentioned, how important population health analytics is, and how important it will continue to be to drive better understanding of an organization's ability to actually successfully deliver on the value-based goals that they have. How do you find that organizations, when you talk about predictive analytics and segmentation, how well can they adapt and adopt these concepts, and how well can they apply them to actually gain value from the types of things that ACG system can deliver to them?
Raheel, that's a really excellent question. And I think you and your listeners know better than anyone that data is only data and models are only models until they're translated into action with a certain level of rigor and measurement. They're data points on a spreadsheet or anything. So we've, over the past 3 years, shifted the approach of our ACG system customer support and implementations so that we're providing not just data tables and predictive model outputs. We share with our customers best practices for implementing their care management and clinical improvement programs. And we've aimed to scale some of our knowledge and best practices approach across countries and across US customers as to how we translate these findings into action. It's very common for our customers, they'll want to know the inputs to a population improvement program, but we can add more value by providing not only the inputs, but how do we monitor that program? What are the best process metrics? And what is the outcome metric that program is enabling?
Wow. So when you zoom out, it seems like the impact from Johns Hopkins ACG system isn't obviously the clear advancements in technology itself to be able to do all of that, but also the assistance in process and process improvement to ensure that organizations are successfully able to absorb this. So for me, that's really the important part, because it's not a software you click button and it goes. There's a significant amount of complexity and, of course, maturity in the platform, the technology itself, but also, the knowledge and the hand-holding and the best practices that come with it. So very exciting to see that. You mentioned a little bit about segmentation and social determinants of health earlier. I also read about your new version of ACG system, V13, introducing concepts of patient needs groups and, of course, HDOH. Can you share a little bit more about that, what they are, and how is it changing how predictive analytics works, or even more importantly, how you can really target the cohorts to drive the right interventions in care needs?
That's a good question. Thank you. So I'll start by defining patient segmentation a little bit. Segmentation is looking at the entire clinical needs of patient groups within the population and grouping patients according to those clinical needs. So we'll contrast that with risk prediction or risk stratification. Many models that you're familiar with, including many of our long-standing ACG models, will categorize a patient's predicted cost or likelihood of readmission as high, medium, or low. That's really excellent when we're thinking about devoting our resources to the highest risk and highest need patients. So we'll always have those models out there, and they're always a great starting point. We've moved into a segmentation approach because the label of high is not always clinically definitive enough to define what does a patient really need as a holistic person when we think about their healthcare needs. None of us can be defined by labels of high, medium, or low, so why would we expect our patients to be? It's not a clinical view.
Right.
So when we think about segments of a population, which is really now becoming a best practice, particularly for complex populations and those in the Medicare and Medicaid space, we're thinking of patients who have a defined set of needs. And how do we best meet those needs? Are some patients frail? Do some need designated support for social determinants of health improvements and services? Do others need basic disease management support to manage their diabetes or other chronic conditions? So we've migrated into that approach through the Johns Hopkins patient need groups. It's 11 defined clinical need groups within a population that allows our clinical partners and those implementing the ACG system to really refine the services and the care pathways that they're providing to certain groups of patients.
Right.
It enables better outcomes, and it enables more transparency when we're asking clinicians to take action.
Yeah. No, makes a lot of sense. And I think when you look at at least from my perspective and from our experience at Productive Edge, the amount of investment and thinking that's going in regarding, how to really drive the understanding from a social determinants of health, how to structure programs at a community and a population level, how to design more targeted interventions, and how to actually understand the efficacy of running those interventions, and the closed loop that is required to do that is quite challenging and is difficult. So for me to hear about how ACG system supports that and enables that is great to hear. And I'm just curious. I mean, have you seen, or are you able to share a couple of examples of organizations that have applied the PNGs and have seen some interesting results?
Yes, we have some very good partners that have applied the PNGs within their care management strategy. And I think the value that they're seeing is exactly what you described. There's been some challenges in measurement of care management success, and, is it a black box? How are we really benefiting patients? As we move into the next era of patient outcome support and improvement within a value-based care model, we need to establish those defined pathways. And then we need to measure process points along those defined pathways in order to ultimately achieve our measure of a successful outcome. So what might that look like? Let's say for a frail patient, we wish to ensure that they have all their meds, they have caregiver support, and they have DME or other in-home services as needed. So we design that into our clinical pathway for those frail patients. We can measure each of those process steps. We can identify where do we better devote our resources, how do we mitigate common barriers, and then we can measure the ultimate outcomes that we're looking to achieve.
Yeah, I mean, that's phenomenal. And as organizations adopt and embrace a lot of the best practices that come along with this from Johns Hopkins, I just think the outcomes and impact I can't wait to see a lot of the stories coming out of that in just being able to quantify the impact. What also excited me, by the way, is a recent blog article that I read on your website that talks about how providers can leverage the ACG system at the point of care. Now, that may be a little bit, extending the impact of ACG system even further within the healthcare care delivery side. Can you shed some light on, how ACG system and how does it actually enable the application of insights ranging from population now to an individual, and how do you imagine that actually happening at the point of care?
Absolutely. And the migration of ACG and other analytic tools into the front end of the EMR is going to be one of the largest drivers of change that we see over the next few years.
Absolutely.
We can't expect people to bounce around between systems, and that's especially true of primary care physicians and specialists who are already stretched thin in terms of time and resources. Many of our Epic using customers and others who have ACG data available in their EMR see select ACG outputs at the point of care. We don't need to show everyone all the measures. So we've made targeted selections of those that are most relevant to clinicians and other office staff within the outpatient setting. So typically, we'll be able to see a measure of risk, a measure of likelihood of readmission for those relevant patients, as well as surfacing opportunities to improve care that could be addressed in the office setting. That may be with a MA, that may even be with someone who's registering the patient. Have they had a lack of primary care? Do they have an opportunity to improve medication adherence? Do they have known social determinant of health barriers that they've reported to a different provider elsewhere within the health system? And in some of our more advanced implementations, including our implementation here at Hopkins, some of those flags drive best practice alerts that can trigger certain referrals right in the office setting.
Right. Oof, that's unbelievable. And, you know, it's so great to hear. And by the way, just curious, how have you all worked with the EMR organizations to make that happen closely to ensure that these insights show up at the right screens in the right places? Is that something that you work closely with them?
Yes, we work very closely with a few EMRs. The largest are Epic, as well as we have a nice piece of functionality that's available within eClinicalWorks.
Right. Wow. Great to hear. I mean, it's really that level of collaboration and, just ensuring that the last mile outcomes are enabled through the type of insights that, of course, are being generated. So it's great to see that it's happening. I think when you were talking about just the ability to, influence at the point of care, um, specific best practices, my mind went to just the application of things like, better patient engagement, communication, capabilities that many are trying to do can be turned on, connected to the EMR. Then you have capabilities around prior authorization and being able to understand, what may be are the things that were needed to support a specific request that can be actually approved, and you've got all the evidence to support that. So when I think about that, largely that process can be made, can be simplified in some way with less friction. That's great to see. So just the offshoot of capabilities that this can turn on within the healthcare environment is just great to imagine that. So great work to see that. I'm curious though, how does this lead to what are the unique advantages of ACG system compared to other population health analytics? There's a lot of emerging models and approaches. I'm curious how you see the market, evolving, and what is a more sustainable approach that you're seeing that eventually will drive a lot of the things that we're talking about here.
Sure. So the ACG system is a whole patient clinical approach to modeling. We look not only at dollars and utilization, but overall patient needs, frailty, medication needs, and the presence of multiple chronic conditions cannot be understated. So it's really tempting to look at a patient as a diabetic or a patient with hypertension. And we know in clinical practice that that's simply not true, particularly when we think about high need and high cost patients, those who have more intense social needs, patients who we tend to see in a Medicare population who might have end of life needs. One chronic disease is manageable, two chronic diseases is manageable, but patients get to a certain point and have a certain number of medications where their risk just starts to multiply exponentially. So this clinical view is important to understand the holistic needs of the patient and drive action. There are other models out there that are really excellent financial models, and they're good for that purpose. But, sometimes it's hard for a case manager or a clinician to understand what's driving the model when we're looking solely at dollars. So there's a little bifurcation in the market of, the clinically oriented models and the financially oriented models, although a lot of great options out there.
Right.
I think, there's wonderful models and wonderful technology to create very accurate models. I would kind of urge your customers to think about the maintenance load and what's the plan for maintaining and translating that model into action.
Agreed.
Many of the larger commercial models are updated quarterly. We have new codes, practices changing, codes are deprecated. If somebody in your organization is building a custom model, but they're not talking about how to maintain it, you have to realize that it has a 12 to 24 month lifespan.
Very true. And, the models are have to be upskilled and maintained, as you said. There's no such thing as a model that will just continue to deliver what is expected to. You have to understand whether it's shifting its recommendations, whether all the factors that went into it are changing fast enough for it, and it needs to be updated and scaled. So very valid point. Zoe, I think we're running close to our time.
We are. We have time for, I think, just one last question. Could you give us a little insight into the future of the ACG system? Any exciting updates or developments that we can look forward to?
Sure. So we continue to evolve the system and have some exciting enhancements planned. We will continue to grow our investment in social determinants of health functionality. We've made some initial movement within our latest release that came out about a year ago. That's had really great adoption. It's called ACG GL Health. From that, we've learned a lot from the market and a lot of new customer needs and new customer requests, particularly as we see the direction of CMS and these state Medicaid programs migrating more and more into requiring health plans and health systems to take action on social needs and social determinants. So we'll continue to grow that functionality as well as making it easy for customers to understand the impact of social determinants on their populations.
That's awesome.
Also making some investments in usability and transparency. How do we better enable these clinical teams to take action? Which, Raheel, I think is something that you had mentioned as a critical success point. And we continue to see that across the industry. So we'll be making some enhancements in that direction within the next version.
Awesome. So much to look forward to. Well, thank you so much for talking with us, Sarah. And thank you again for joining us, Raheel. It was great to have you both on. And thank you for tuning in. And we'll see you next time on the Health Tech Edge. Take care, everyone.
Thanks, Zoe. It was a pleasure.
Thank you.